So it's my great pleasure now to welcome by Zoom, unfortunately, the Professor Dror Meirow. He cannot join us today because he was not able to come from Israel. As you know, Professor Dror is the director of the Maurice Kahn Center for Fertility Preservation Division in Obstetrics and Gynecology at Sheba Medical Center in Israel, and he's the director of gynecology care in breast cancer patients at Sheba Medical Center. He's also full professor at Sheckler Faculty of Medicine in Tel Aviv. So he founded the Clinical Center for Fertility Preservation, and I will talk about reimplantation of malignant tissue today by Zoom. I'm really happy to welcome you, Dror, and I hope you are safe as well as your family in Israel. Please, the floor is yours.
Hello, thank you very much. Do you hear me, please?
Yes.
Do you hear me?
Yes.
Okay. So I will start. I want really to thank you very much for inviting me to the Oncofertility conference, which I gladly accepted. I wanted very much to come on site. However, on the 7th of October, a Hamas terror organization launched a brutal attack against children, babies, women, and men sleeping in home in their bed. More than 1,400 people were slaughtered by unspeakable ways, and 240 babies, children, and adults were taken to underground tunnels in Gaza. We have no clue about their condition. This terror attack initiated a circle of loss and suffering of both nations, Israelis and Palestinians. We are in the business of creating and preserving life. We all deserve safe life. So reimplantation of malignant tissue. So it's very easy to answer this question. Reimplantation of malignant tissue, the study answer, no, we do not transplant malignant ovarian tissue. But the study question should be fertility preservation in patients with cancer or cancer cells in the ovary. What can we do? So we are really running a very busy fertility preservation center. We have more than 1,100 consultations annually. We perform more than 70 cases of ovarian tissue freezing or transplantation annually, and more than 200 cycles of IVF for fertility preservation. And we are checking for cancer cells very intensively, as I will show, in more than 85 cases. The unique place of us is also by that one team is doing all the procedure. We give the consultation, we run the clinic of monitoring, and we make the fertility preservation and fertility treatment thereafter. So we make the ovarian tissue cryopreservation, we check for cancer cells, and we make the transplantation all by one team. And we also make the IVF afterwards if needed. And also we perform the cycles of IVF, of oocyte or embryo freezing, and then hopefully reaching to live births. So this is coming from Marie-Madeleine Dormans in the New England, but you can see we have two options, and all this should be addressed initially when the patient initially come to the clinic. What should we recommend? Ovarian tissue freezing or oocyte and embryo freezing? So the question of safety, yes?
Dror, can you hear me? Can you
Yes?
put the full screen, please, for the slide?
For me, it's full screen.
No, you are not sharing the, we are sharing your presentation not as a full screen, so can you try to do it, yeah. No, you're sharing individual.
Now it's okay?
You need to do F5 and share the right screen in your computer.
Now you see the full screen?
No.
Sorry. We checked it yesterday.
Do start slideshow.
Second screen. Okay. How it is now?
No.
No, it's the same.
How is it now?
No, it's not full screen. We're seeing the one with the slide on the side. You need to stop sharing and reshare, I think.
Okay, maybe.
Sorry, because we were missing on the presentation.
I stopped.
Yeah. So now we see you. Can you start to reshare your screen?
Now?
No, we just saw you. We're just seeing you.
Now?
No, there is no screen.
He has not sent the presentation.
I see full screen.
We have the presentation here. Did you send it? Maybe we
No,
can do it. Oh.
no. And maybe now?
No, we just see you.
You have two screens at your home, maybe just...
I have, but I checked to one screen, two screens, all of them are checked together. I can stop. Can you share me?
What does that mean? Can you show me?
How is it now?
Okay, so maybe you just move your slide. Every time you move, you just move your slide. I think it's better because you just move your slide. We saw one slide every time.
Now you see one slide?
We see all the slide on the side and one main. So just move, as you speak, just move to the right slide.
Click on the right slide to be sure that we...
Okay, now you see this slide of Marie-Madeleine?
Consultation, choosing...
Yeah, okay.
Yeah,
so,
yes.
So is it convenient? Can I continue like this?
Yes.
No, it's okay.
Can I continue?
Yes.
Yes, please.
Okay, so when we need it, we have to choose the proper fertility preservation technique at the time of first consultation, and we have to consider the age, the safety, if the patient received previous chemotherapy, and also considering the success rate. So reimplantation of when you have cancer in the ovaries, so in ovarian cancer, we will not perform ovarian tissue cryopreservation. When we have large ovarian metastases like GI or breast, we will not perform ovarian tissue cryopreservation. In lymphoma cases, when there is lymphoma in the ovaries, we will not. In cases of minimal residual disease in ovaries, we'll go for clinical ovarian tissue cryopreservation. So this is an old publication from Human Reproduction 2008. The first case that the group of patients that we looked for ovarian involvement in cancer, and you can see here just the beginning that we perform sonography or other modalities, CT or whatever is indicated, to see that there is no disease in the ovaries. And in such cases, like in a B-cell non-Hodgkin lymphoma and in the Burkitt case, we did not perform ovarian tissue freezing, and that's what we do today. This is the case, and it should be very close to the time that you freeze the ovarian tissue, because you can find that here 2 months prior to OTCP, that the pelvis was normal.
Sorry to interrupt you, but can you move to the slide that you're describing right now? Because we still see the original slide with Meirow Madlan's publication. We see the consultation choosing the proper fertility preservation technique. We see this slide. We don't see the slide that you're referring right now.
I don't know what's going on.
So just click on the slide you want to show on the... Yeah.
Yes.
Exactly.
I will do it like this, okay?
Yes,
Yes,
exactly.
thank you.
Thank you.
Sorry. Okay, so I'll go again. Sorry, implantation of malignant tissue, not in ovarian case, not in ovarian cancer, not in ovarian metastasis, not in lymphoma when you have disease in the ovary, but when you consider minimal residual disease, yes, we perform. And this is for the first case that we published about evaluation of cancer cells. So you can see here, when there was a disease in the ovaries, we did not perform ovarian tissue freezing. These cases are excluded, and this should be done very close to the operation, because here you can see a lymphoma patient with normal pelvis, and just prior to ovarian tissue freezing, she had a huge metastasis, lymphoma in the ovary. So, but what we can offer to patients with ovarian involvement, so this is a case of borderline ovarian tumor. As we said, ovarian tissue cryopreservation will not perform, first, because the risk of tumor cells, but second, also, if you remove one ovary and then you have disease in the other ovary, to take more tissue for freezing, it's better to leave the tissue intact in place. So the other option would be to perform oocyte or embryo freezing. But what are the risks of ovarian stimulation? What are the risks of puncturing and maybe touching the tumor? And also, what is the oocyte quality? So this is a recent work done by our Dr. Shai Daniel, that this is collaboration with San Raffaele Hospital in Milan, Italy, and fertility preservation and looking into safety issues in borderline ovarian tumor. So you can see that all criteria of those who had ovarian control stimulation and those who did not was very similar. This is the largest group in the world. 165 patients were enrolled to this study, and there were no differences in the other criteria. And multivariant analysis factor associated with recurrence rate, you can see that IVF, the puncturing or the stimulation, did not result in any differences with the patients who underwent fertility preservation, and the only factor was the stage. And indeed, the oocyte retrieve were good, and we received oocyte that were cryopreserved, and we had pregnancies and live births thereafter. So if we want to conclude this is the largest study of borderline ovarian tumor patients underwent IVF, even in advanced stages. It does not increase recurrence risk, and fertility preservation showed a real chance of live birth in borderline ovarian tumor patients. Patients undergoing fertility preservations had similar recurrence rate, and all recurrence rate were the same stage. So this is very ensuring. What about minimal residual disease? And we are approaching the safety and looking on the safety of ovarian tissue freezing and transplantation already from the beginning, actually from the first publication of ovarian tissue freezing in '96 in the editorial corner of fertility sterility. And we are working on this all the time, as well as other work. Especially involved is Professor Andersen from Denmark, and also the other groups like the group from Belgium. So to safety and successfully manage ovarian tissue cryopreservation transplantation program in a very busy oncofertility preservation center, I will focus and show you our results. So the success rate is real good. You can see here a publication of us and also other publication showing that really after transplantation of ovarian tissue, you can reach up to 95% of menstrual resumption, at least one pregnancy in 50%, and at least one delivery in 40%. And other publications show somehow lower results, but all show that this really well work. So we have at Sheba performed more than 800 cases done by one team of cryopreservation of ovarian tissue. And if I look at the group of different diseases, you can see that almost 100 patients underwent ovarian tissue freezing, and the mean age of this group of the leukemia patient was 19. So the way we deal with our patients is we initially start chemotherapy. And this is by several reasons. The patients are too sick. We had cases coming from other hospitals that started stimulation and had to stop in the middle because of medical disasters, and they need to initiate chemotherapy immediately. And then the first line of chemotherapy for AML definitely, but also the first cycles of treatment in ALL are not so gonadotoxic whatsoever. So you can do it and will not lose too many of the ovarian reserve and the follicle. And then we look on patients that have complete molecular remission. And the only way to perform fertility preservation at this stage is to make ovarian tissue cryopreservation. You cannot stimulate the ovary at all these stages. And then we perform ovarian tissue freezing before high-dose chemotherapy. And when the patient wants to conceive, she comes back, we freeze special ovarian tissue for evaluation, and I will show later what we are doing with this tissue. Indeed, you can see that freezing ovarian tissue collected after exposure to chemotherapy gives good results. It's published by several groups. And if we look on our publication on this, that was published by Dr. Moran Shapira from our group and gathered the publication from the group from Belgium and Sherman Silber. And you can see here that there was no difference in menses recurrence, pregnancy rate, and live birth among patients who received chemotherapy prior to ovarian tissue freezing and those who did not. So this is very reassuring. So the success rate is good. So what about looking for minimal residual disease in the ovary? Initially, when we take the ovarian tissue, we send for conventional pathology, but this is not the need before transplantation of ovarian tissue. And for this, we do a very deep work. And actually, we had almost 10% of our patients who came asking for a tissue evaluation before transplantation. And you can see here, these are the indication that we looked for the disease in the stored ovarian tissue. And some of them, it's very easy, just conventional immunohistochemistry and histology, but not for the leukemias and the sarcomas, and I will explain. So one of the methods that we performed is taking the primary tumor and looking for molecular markers, and if we find them, we go for the ovarian tissue and look for those markers in the ovarian tissue. And this is a case that you do not have markers. But anyway, we perform all stages of evaluation, histology, fission cytochemistry is indicated, real PCR and NGS, and also we transplant ovarian tissue into immunosuppressed mice for several months and evaluate for disease. So this was published in at the ESHRE meeting by Dr. Hilar Ranani and Dr. Sadas Der-Chaim from our group, improving the safety of ovarian transplantation in order to restore fertility in leukemia patients' survival. So we had 21 leukemia patients, and these were the diagnoses. And when you have well-known molecular markers at diagnosis, you can check them in the tumor, and you can check them in the thawed ovary. When you have known molecular markers, you can see here that by PCR, you can find them, but on some occasions, the molecular investigation will be negative, but you can see them with the animal xenografting procedure. So it is very important to do everything you know, because some cases you will see by different methods. When you don't have molecular markers at diagnosis, then we preferred, like in AML, we have myeloid sequencing panel that you can look for those if you can see something. And this is looking in general when you don't find a marker. So this is a huge work that takes actually months. But in summary, you can see here that it brings you to a state that you can perform ovarian tissue transplantation, excluding patients when you find positive MRD, and we really found. And up to today, we performed 7 cases of ovarian tissue transplantation in leukemia patients. What about ALL? Also in ALL, you have the real-time PCR, and you can find markers positive. So we have patients that were positive and we didn't transplant the ovarian tissue, but we have patients that all investigation was negative and we made the transplantation. With CML, it's much more easy with the PCR able, and you can see one patient was positive and one patient was negative. So when we have all those patients with positive minimal residual disease, all of them were denied. Even if you find it by real-time PCR, by PCR, or by xenografting, all these cases, we did not perform transplantation of ovarian tissue. However, it brought us to this. We had patients that all were negative, and then we transplanted the ovarian tissue into 7 patients, and we have, for example, for the AML, 3 of the 4 patients conceived. We achieved 8 pregnancies and 4 deliveries, and also of the ALL, we have 1 patient that conceived and 1 patient that is ongoing. So this will give you really good chances. So about the safety, most leukemia survivors that cryopreserve ovarian tissue as indications can benefit safely and successfully ovarian tissue transplantation. We have to use multiple techniques in order to go into good evaluation. And for patients proved to be contaminated ovarian tissue, future technique development is needed for rescuing fertility potential in frozen tissue. So how do we perform this transplantation? I will show you 2 short videos, the way we perform them. And as I said, one team has performed all 80 free transplantation of ovarian tissue. It is all done today by laparoscopy. We put a suture to handle both sides of the pocket. We put the ovarian tissue inside, and we close the suture. This can be done in the ovary. We prefer transplantation in the ovary or to the peritoneum pocket. This can be done also by clips in the peritoneum. And if it's very small pieces, and this was published by Dr. Safrai, that is now in the audience from our group, as it's very similar. But we use the pipelle to put the very small pieces that are put together, and we put them in the pocket, and also into the peritoneal pocket. You can see here the small fragments. And this is the way we perform all our transplantation. And indeed, the success rate is very good. We had 83 transplantation, and we have a high pregnancy and delivery, as was shown before. But what I want to show here for the leukemia patients, we have of 7 patients, 4 conceived, and we have the deliveries, and actually multiple deliveries. And this is the patient that had 4 children born after transplantation of ovarian tissue. Actually, all the family was created by transplantation of ovarian tissue. So we get there by prolonged endocrine function, prolonged fertility, and repeated pregnancies. But as I said, there are cases that you will find malignant cell in the ovarian tissue. So what are the future options? So this is all under investigation, working on artificial ovary or purging ovarian tissue contaminated with malignant cells, follicular in vitro maturation from ovarian cortex, and maturation of oocytes from ovarian cortex by xenotransplantation. Follicular in vitro maturation for ovarian cortex was published by several groups, but the limiting step is the activation of follicles that is not sufficient today. And xenotransplantation, just hypothetically, you can take contaminated ovarian tissue, put it into an animal, grow oocytes there, take them, fertilized, and put it back to the woman, and get pregnancy and live birth. But this is our research and not clinically used today, and we also do not consider it as a mean. By working with those high-risk patients, especially the leukemia patients, as you saw, many of them are very young. And stress is always present while discussing fertility preservation, significantly more pronounced in children and their parents. And we are working a lot on this. And this is, for example, a child with leukemia that came for us from a neighbor country, and with her father, and they needed cryopreservation of ovarian tissue. And in order to ease them, we have created a short cartoon in 3 languages, Hebrew, Arabic, and English, and I will be happy to share this with you.
If you have just been given a diagnosis of cancer, I'm sure you must have received a lot of information about your medical treatment on your way to recovery. Some of the information is also related to the process of fertility preservation. I'm sure a lot of thoughts, questions, and concerns are coming up now. So let's start from the beginning. Make sure your parents are near you, and there is enough silence so you can hear, and we will explain everything. All along the way, you and your parents can ask the medical staff any questions you have. So what is fertility preservation?
Fertility preservation is the medical procedure that children who receive chemotherapy or radiation undergo in order to have the possibility that one day as adults, you will be able to have children, if you want, of course. The ovaries are here in the lower part of the abdomen, which contains a lot of healthy eggs that can be damaged by the treatment usually given to cancer. The purpose of a fertility preservation procedure is to collect, keep, and protect the eggs so that they will not be damaged by the chemotherapy treatment. Many parents think that their daughter is too young to understand what the fertility preservation procedure means, or that it is not suitable for them due to her young age. However, it is important to know The ability to have children depends on the egg stock that is already there from the day we are born. The decision regarding the need for fertility preservation and which medical procedure is suitable for each patient is made by the fertility preservation team and the oncology team treating you. And it depends on your gender, your age, and the type of treatment you are expected to receive. At the first step, you will meet the medical staff at the clinic who are experts.
Okay, I will stop this movie here, but it runs about 3 to 4 minutes and explain all the steps in order to alleviate the anxiety that we all see for those cases. I would like to hand here. I really appreciate and very thankful for listening to me. The fertility preservation at Sheba has collaboration with the IVF team. We have the research lab, the Cancer Research Center, and the Pathology Institute. And I thank you very much for listening to me. Thank you.
Thank you very much for this nice presentation. We have time for a short question if there is in the audience. Yes.
Hello. Can you hear me? Just out of curiosity.
Yes, you can hear us?
Hello.
Yes, I can hear.
Okay.
Yes, yes.
Excellent. Thank you so much for this fantastic talk on how to preserve fertility and potentially reimplant tissues in leukemia patients. I was curious about when I saw that procedure of the grafting into a peritoneal pouch. How is it that during ovulation an egg is able to make its way out of that pouch in the peritoneum?
Okay, well, it makes it in all cases. I cannot actually say if the oocyte comes from a transplanted ovary or transplanted into the peritoneum, but we have cases that we transplanting only to the peritoneum and the egg finds its way. Also, you know, when in the ovary, when the oocyte grows, it grows actually not outside, it grows inside. And only then, when it comes to ovulation, it goes outside. So they found a way. We don't need to do IVF. Actually, only 50% of our pregnancy are IVF. You don't need to do IVF because you transplant to the peritoneum.
Thank you so much.
Thank you so much for a wonderful presentation. I have a question. Maybe it's a little bit of naive question, but you have been testing MRD in the ovarian tissue, but what about if you have the patient who had the chemotherapy and they did the bone marrow biopsy on flow cytometry, there is still MRD in the bone marrow biopsy. Do you assume automatically that there are also cancer cells in the ovarian tissue and you just give up on collecting that tissue, or you still collect hoping that in the future we'll be able to actually mature the eggs from the ovarian tissue?
Well, this is not an easy question. We had cases that leukemia patients had chronically positive markers, which actually do not imply that they are not healthy. And the oncologists say they are healthy with positive markers. Nevertheless, because we do the treatment and it's our obligation, we investigate the tissue. And if we found positive marker, we had patients like this approaching us, we did not agree to transplant the ovarian tissue, although you can say, yes, but the patient also has positive markers, but what does it mean? But we had to stick to something, and we work for leukemia patients. Sometimes it's 8 to 10 months investigation before you allow the patient to go transplantation. And we do all this work, and if it turns to be positive, we will not do it.
Thank you.
So maybe a very short question, and then we have to close the session. Sorry about the people who wait for that.
Okay, quick question. This is fantastic work. Olivia of Cincinnati Children's. With the tissue that you are finding is MRD positive, what are you then doing with that tissue? It seems like that's a great group of patients to then enroll into a research study where then could those be the patients where you actually can do IVM and utilize that because that would be then their last ditch effort. But do you refreeze that tissue or are you only testing a sampling and there is still remaining tissue?
Okay. As those patients who cryopreserve ovarian tissue from leukemia had chemotherapy before freezing the ovarian tissue, we will not allow them to go for any IVM procedure, as we will not allow them to go for IVF procedure, because we and others have published before that there are enormous genetic problems that leading to, in animals, to 80% abortions and 30% major malformations. And this was shown genetically and also morphologically, and also with pregnancy evaluation, that any stage of follicle that is growing, and for IVM you use growing follicles, is not suitable for this procedure. The only way you have the dichotomic situation is with the primordial follicle. If it alives, it is okay, 100% okay. And if it's not okay, he's dying.
Thank you very much. You can stop sharing your screen so we can see you to say bye-bye. And thank you very much for this very nice presentation. It's time now for a break. So thank you, Dror. Thank you very much.
Thank you very much.
So we will have 10 minutes breaks if it's okay for you. And so we can start again at 50. So for those who have posters, you can place your poster. And the number corresponds to the number in the program, and it's at lunch outside in the foyer. Thank you.